Hello, I'm Sarah Day, Policy and Research Manager at HFMA, and you're listening to HFMA Talk, the podcast for NHS Finance. The HFMA is not just a UK organisation. There are HFMAs in the USA and Australia too, and this episode is truly international. We start by hearing from Shaun Eldridge, President of HFMA Australia and Chief Financial Officer at Bendigo Health in Victoria. For them, Covid-19 is hitting just as they approach their flu season, so they are attempting to manage the disease very closely and seem to be having some success so far. By contrast, we then speak to Joe Fifer, Chief Executive of HFMA USA, who shares a broad range of experience from members across the United States. The cancellation of elective procedures is having a huge financial impact on their healthcare system, but while we may hear a lot in our media about partisan politics in the country, aid packages and support are being agreed with very little challenge. The USA and Australia may be a long way away, but the challenges and the solutions being tried are very similar to our own. There are lessons to be learnt and shared from across the globe. So without further ado, let's hear from Shaun. Hello Shaun, thank you for joining us today all the way from Australia. Could you introduce yourself and tell us a bit about how you came to be involved in this?
Thanks, Sarah. Yes, I can. I'm actually the president of HFMA Australia, and I'm working in Bendigo Health, which is in the state of Victoria in Australia. For those who are familiar with Australia, it's in the bottom right hand, but not quite separated by sea like Tasmania. How have I become available to be in this? Clearly, there's something that's embracing our globe at the moment, being the COVID-19 virus, and I think both Australia and the UK, and I understand also America, we're all probably reacting to this scenario a little bit differently. So we just felt that it was a good opportunity to get together, have a bit of a discussion about what's happening in Australia, and try and glean a bit from what we're doing over here.
Thank you. So people listening are probably not that familiar with the Australian healthcare system. So can you give us a brief overview, like who funds it and whether it varies between the states?
It does vary between the states. So the funding of the health system is done it's done from a few different sources. So firstly, the Commonwealth funds part of the general health system. The Commonwealth, though, does fund our Medicare system. So the Medicare system, basically all of our GP attendances, Medicare, which is the Commonwealth system, will pay for quite a portion of that. Certainly, if the doctors are bulk billing, that's covered by the Medicare system. As far as the broader health system, so talking about acute health, that's actually a bit of a mix. So the Commonwealth funds part of that system, around about 45%, and that's through a model called the National Weighted Activity Model. And then the states fund the balance. So that's the states are actually responsible for running the hospitals in their state or territory. There's six states and 2 territories within Australia, and each of them does it slightly differently.
Can you tell us a little bit about your own organisation then, where you fit into the system?
Sure. So we are what's known as a regional hospital within the Victorian system. So the Victorian system is made up of around about 86 individual hospitals of varying sizes. Our budget, which I haven't converted to English currency, but our budget's about $550 million Australian, and it's quite a varied organisation. So it looks after a number of different areas. So not only does it look after acute care and have all that acute care has in it, such as ICU, special care babies unit, mental health, allied health and palliative care. It also has a number of residential aged care facilities that it actually runs. It caters to basically it caters to the regional city, if you like, but also a lot of the outskirts, and it has programs running out of many other different cities and towns throughout Victoria, predominantly north.
So obviously COVID-19 is affecting Australia, but looking at the recent Australian government statistics, it seems the number of cases are really quite low, and most of these can be traced back to foreign travel. So I was wondering what the approach is to tackling the spread in Australia and how you're managing to contain it so effectively.
Yeah, so I think at last count, the number of cases in Australia was up over 6,000. Victoria currently has about 1,291 cases. I've had 14 deaths, which is probably low in comparison to a lot of other countries. And there's a suggestion that 1,118 of those 1,291 cases have recovered. At a local level in Bendigo, we've had 9 cases, so it's quite small. How have we gone about making sure that we don't have as many cases and that we don't have spread? We've put some stringent, and I think they hesitate to call them lockdown, but it's like some lockdown measures. So there has to be a good reason for you to leave your house. I'm working from home at the moment, and probably 50% of my staff are, so around about 55 people working from home. Also, the 4 reasons to go out are if it's related to getting health assistance, exercising, which is generally walking or going for a run with social distancing, clearly. Also, if you're trying to get food or supplies, so provisions, or you're heading out for work within some defined industries. So I guess in keeping things down, we're obviously an island nation, if you like, covered all the way around us is water. So I guess that's something that sort of helps us where other countries might have a bit more crossing of borders.
Yeah. So is it impacting how you're running your organisation and delivering services then? Obviously you've got people working at home, but is it having any other impact as well?
It is. I actually think our organisation has been at the forefront of making early decisions. We've got a fairly ahead of the curve CEO who is keen to, I think in his words, he'd prefer to be remembered for being out front and not needing it rather than not being out front and having to explain why we weren't. So he's taken a focus to ensure that we're doing all we can. I guess we've made a lot of calls on things like visitor numbers, how often, how long they can spend on what's, you know, in what circumstances. So there's been quite a difference in that respect. We've also seen how quickly the organisation's been able to mobilise itself. We are in the fortunate position in Bendigo where we've just opened a new hospital and the old hospital is still co-located on site, so we were able to utilise some of the facilities of the old hospital to set up screening clinics, those types of things. So that's been really helpful. I guess my colleagues would describe us as being in a bit of a cat-like state ready for what actually is coming next, because we've actually entered into some arrangements, or the state's entered into some arrangements with the private hospital setting, and has allowed us to work in conjunction with the private hospital. So we've started decanting some of our beds, particularly in the rehab area, into a different hospital in preparedness for what might come. Naturally, we are hoping that we don't need those beds, but at the moment we've got a lot of spare beds in anticipation of what might be ahead of us.
And are you anticipating quite a peak to come yet then?
So there's been projections, and the projections have been changing. A lot of projections are suggesting that June, July are going to be quite a big time for us. I look at how well we seem to have contained it, and I'm hopeful that with everything that we've done, that it's not going to get too much worse. But I think we'd be kidding ourselves if we just believed that wasn't going to happen without leaving in place the measures that we've got in place to try and keep ourselves keep ourselves ready for an increase in the curve. Our curve in Victoria seemed to head up quite sharply and is now flattening out. We're very conscious that we're coming into the flu season as well, the influenza season. So influenza in conjunction with coronavirus would not be a good mix. So we're very focused on that. But what we are finding is with social isolation that we're having less cases of influenza, as well as people keep themselves isolated from others. So it's having a good impact on two fronts.
We've seen in some of our hospitals and A&E, we've seen a drop in attendances for other issues, less strokes, less heart attacks and the like, which suggests perhaps people aren't seeking care when they need it. Are you seeing anything similar in Australia? Absolutely.
So we're seeing all these emergency key performance indicators and targets that we're meant to be meeting, where we would traditionally struggle to meet those targets, but we're meeting them quite easily at the moment, and finding that we're actually sending some of our staff off on leave because the numbers through our emergency department have absolutely dropped. And the same with our bed stock. So whilst as I said, we were decanting some of our rehabilitation patients, we've got a number of beds throughout the hospital that are empty, which is pretty unheard of when the pressure's on, but people are keeping away and looking after themselves, so that's a good thing.
And one of the discussions that is being had a lot all over the world, I think, is around PPE and ventilators. Again, is that something which you're battling with in Victoria?
Absolutely. So part of my role as the Executive Director of Finance and Resources, so not only do I wear the Chief Finance Officer hat, I also wear the Chief Purchasing Officer hat as well. So very, very focused. In fact, that's probably where probably 50 to 60% of my focus is at the moment, is in making sure that we've got PPE. It would be fair to say we've, as the state of Victoria, the state's approached it a bit differently in that they've opened a central warehouse which is managing the key PPE items through it. We found ourselves a little bit ahead of the curve in that when we saw what was going on overseas, we had a chief materials management director who took the initiative to ensure that we had a lot of stock in very early. So we've been benefiting from that. The big items that we're struggling with over here are swabs and gowns are probably two of our big ones, and the other one's probably thermometers. So it's just very, very hard to get those items. And when you're relying on them coming from overseas and in a lot of cases coming from China, that puts a whole lot of pressure on, and I'm sure you've seen similar in the UK.
Yeah, absolutely. What approach are you taking to testing people with symptoms at the moment?
So initially with the concerns around PPE, we probably took a fairly targeted approach. So people needed to pretty much exhibit all the symptoms. But today, the Victorian Health Minister advised that anyone that's got flu-like or respiratory symptoms now will be tested. Our concern with that, in part, is that we are very short on the swabs and the testing kits. So being able to cope with that would be of concern, although we're finding that our testing clinics, our screening clinic has dropped away in numbers quite considerably at the moment, so it's not a problem at present.
So have you learnt anything about how your system works as a consequence of COVID-19? And have you had any lessons that will change perhaps how you operate when the pandemic is over?
I think it's been really interesting to see how the workforce has responded. I know in the past we've always talked about having contingency plans for if we have a disaster, and this whilst we haven't declared it to be a disaster or a code brown as we would call it in Australia, I think that it's shown us, particularly in the finance area, that we can work off-site and work effectively from home as long as we've got an intact IT system that allows us to continue to operate. So I think that it will allow us to perhaps change our employment arrangements a bit to become a little bit more creative in how we might do that. I think from a systems perspective, I guess one of the learnings that I've had is watching our CEO here lead early, and I actually think that takes a lot of guts to head out and be ahead of the pack, and potentially do that with the Department of Health lagging a bit behind. So I think for me that's been a bit of a learning that in these times you need to put yourself in front of the pack so that you have better outcomes. I think it's shown that, as I said, half of my team's at home, half of them is still on site, but the focus that brings everybody together to get things done has been outstanding. There's been a few issues that have occurred in the metro areas. They've had issues with car parking and other major things that we haven't had locally, because I guess whilst we still have car parks that we run, the focus has been on working together, not on some of the other issues that sit around that. So having people from different disciplines come together around the table, I think has been a learning, and I guess different people from different disciplines learning the value of everybody around the table. So I'll probably approach things a little bit differently moving forward, particularly in involving our clinicians a bit more in some of the everyday decisions.
Excellent, thank you. It's been really fascinating talking to you, Shaun, and hearing a perspective from completely the other side of the world, but also hearing how similar a lot of the issues are that we're facing and the approaches that we're taking. So it's been really helpful to talk to you. Thank you, Shaun.
Thanks very much, Sarah, for the opportunity, and take the opportunity from HFMA Australia and from my finance colleagues around the nation to wish you guys all the best in how you're attacking the virus that is in front of us, and hope that you guys see a big turnaround over there as well.
And now we move from Australia to the USA and join Joe Fifer in Michigan. Hello, Joe. Thank you so much for joining us today, all the way from America.
Thank you for having me.
Oh, that's no problem. Could you just explain how you've come to be involved in this and what your role is?
Well, again, it's just a pleasure to join you, and this is the first time for me to speak with the HFMA UK members, and so, again, thank you for having me. My role at HFMA is I'm the president and chief executive officer, and so what I tell people when I come across the pond is I'm the Mark Knight of the United States.
Excellent. Thank you. So could you start by just giving us a brief overview of the healthcare system in the US and how it's funded? And I know that's really complex, so just thinking specifically, how would the care of someone with Covid-19 be paid for? My understanding is there's really two main groups, the insured and the uninsured.
Well, oh my gosh, that is a very simple question and a very complex answer. So I'll do my best to simplify this as much as I can. It really is kind of three groups that in terms of COVID-19, but I'll get to that in a moment. Our health system is primarily based on a split between government-provided insurance coverage and employer-based. On the government side, we have two different programs. There's variations within each, but generally speaking, two different programs. One, Medicare, which is care for the elderly, and then Medicaid, which is care for the poor or indigent population. And part of the difference between those two is that Medicare is administered by our federal government, whereas Medicaid, part of the funding comes from the federal government, part of the funding comes from the states, but it is administered or run by each individual state. So each state has their own, now there's some similarities, but each state has their own criteria for who qualifies for Medicaid, and it's typically as a percentage of a poverty level. So, for example, a state might have anybody qualifies for Medicaid at if their family income is less than 400% of the poverty level. So all of that is a simplistic view of our government side. On the employer-based side, most people, as part of their employment arrangement, have health insurance that's provided. And of course, there's all kinds of private insurance companies. Some are larger than others. Some cover the whole country. Others cover a certain geography. The third component, and you alluded to it in your question, is that unfortunately, and much to the chagrin of many, we have a significant number of people that without health insurance in this country. And I think there's somewhere around 25 million of uninsured folks in the U.S. And that's so within all of that, those three components, there's a tremendous amount of complexity. And I know that when people come over from the UK to look at a health system in the United States and we take them to our billing offices, they're amazed at how many people that we have that do coding and billing because the rules through all of these different programs vary significantly. Specifically for COVID in this environment, I might say one more thing. Most plans, and especially on the employer-based side, have either co-insurance, which is the individual pays for a percentage of a service that's provided, maybe 10%, maybe 20%. In deductibles, whereas an individual would be responsible for the first X number of dollars of healthcare claims, maybe $1,000, maybe $2,500, maybe even $5,000 for an individual or a family. Now, to get to the COVID, these are covered services, so the health plans and the government are covering those. Most plans have waived or are not collecting the deductibles, and so most individuals, if they have insurance, are able to get coverage for COVID testing. The services that are rendered for a COVID patient are covered typically without coinsurance or deductibles. So that's a very simple answer to a very complex health insurance environment in the United States.
Yeah, definitely. So in theory, how much autonomy do the states have in deciding upon their response to the disease?
Well, in short, a lot. And you have to keep in mind that even the origin of our country and even the name of our country, the United States of America, and that is that we have a long history of debate, really, not just healthcare, but all kinds of policy issues, a long debate about states' rights, what control each individual state has versus control by the federal government. And one of the things about the United States that's a little bit different from the UK is that my perception is anyway, that the UK population is more comfortable with nationwide policy, whereas there are a number of people in the United States that feel very strongly about individual states' rights. So the states have a lot of autonomy when deciding about the response to the disease. I know President Trump made some comments the other day about that that he alone has the ability to open up our economy. I'm not a lawyer and I'm not a constitutional expert, but conventional wisdom by so many people have made comments that his comments really violate our United States Constitution. So it's a long list of rhetorical comments that comes from our president, and but the essence of that question is that the states have again a tremendous amount of authority, not just with our state regulated insurance arrangement, but even in our social distancing, our stay at home policies are all really done at a state by state level. So again, in short, the states have a lot of control over when to open up the economy again. The states have a lot of control over how insurance works in each individual state. And many times our federal government is in a situation of trying to encourage people to, or states to do things, but don't really have the authority.
Okay. So does that mean that the way that the country is reacting in terms of, say, lockdown and social distancing varies across all of the states? It's not one common policy.
Yeah, technically and specifically, the answer to your question is yes. There's not one state or nationwide policy. I would say that most states, I mean, there's a lot of commonality about, or at each state about what those lockdown policies are. There's a few states that are kind of anomalies in terms of they may not be as strict as others. I know my state, the state of Michigan, where I live, our governor is because our state is one of the highest levels of confirmed cases, mostly in the Detroit area. Our state has pretty strict lockdown policies right now, and those would be different from our neighboring states right around us. So there is some variation around the country, but generally speaking, they're pretty consistent.
So much of what we're hearing here about the situation in America links back to politics. I mean, the whole worldwide response to COVID-19 is very political, but it sounds to us as if the situation is getting treated very differently depending upon whether it has a Republican or a Democrat outlook. And I'm just wondering that from a healthcare point of view, are the politics making it difficult to respond to the disease as you might wish, or are we only hearing one perspective on it?
Well, I guess my first thought is that you should be careful and not overplay what you either read about or watch on TV coming from the media. One of the differences, again, this is my perception anyway, well, this part's not a perception. This part is very clear. Our media is very partisan. If you tune into, Fox versus MSNBC, it's almost like you're listening to two completely different stories. And my perception is that's quite different from what at least what I've experienced when I've come across the pond and what I've experienced with BBC or Sky. And so that's one big difference is, and that so the reporting is very political, and it plays into a very divisive atmosphere that we have here in this country. So I think I would just think about a word of caution about whether politics is driving a significant amount of difference depending on if they're Republican or Democrat. Now, there are some differences, but these relief packages, first there was a $1 trillion relief package, then a $2 trillion relief package, and there's another one brewing in our Congress that will likely be passed. Those things passed in lightning speed with very little resistance, and there was some bickering in there between the two different parties, but by and large, the way I would state is that by and large, the decisions that are being made are both at a state level and at a federal level are relatively apolitical. They're getting through it, and much more so than what the media would describe.
Well, that's good to hear. So we mostly hear about New York, again, obviously, and we've heard that New York needs 30,000 more ventilators, and I'm assuming that many other states are in need of more equipment, and obviously personal protective equipment in short supply everywhere. So how are you dealing with these shortages?
Well, that's one of the biggest dilemmas with this environment, and I speak with some personal interest in this. My daughter is what we call here a physician assistant. That role, and I can't remember the equivalent term over in the UK, but you have a similar role that they can do a lot of what a physician does. They can prescribe drugs, and they, like in her case, she takes care of cardiac and pulmonary patients in our intensive care unit in one of our hospitals. And so I've talked with her about, this whole issue of supplies, and it is a big issue. She is reusing masks, the N95 masks. There are bidding wars, and scams. I know hospitals have thought they were purchasing supplies, and then it turned out to be some kind of a scam, or the supplies got held up at the border for some reason. And it's an issue. I don't know about the 30,000 ventilators in New York. I think that probably is a little bit of an exaggeration, and the numbers are starting to level off in New York City. So there's hope there. But generally speaking, this issue of supplies is a very significant issue. And here's another example, and I heard about this one just yesterday. I heard about this from some of our members that what they used to spend maybe 50 cents per N95 mask. And just to keep in perspective, $1 in the U.S. is worth about 79 cents, at least when I looked last night. So when I quote some of these numbers, that gives you perspective. So before this pandemic, they were spending about 50 cents per N95 mask. Now it's not uncommon for our members in their hospitals to report having to buy N95 masks for $5 per mask.
Wow. And
so that's really disconcerting, and I don't know the reason behind that other than price gouging, which is pretty upsetting. So those are the kinds of issues that they're dealing with. There was shortages of the ventilators, but one of the things that's happening here is that there's been a tremendous support from the private sector. And so we have some of our manufacturing companies that are repurposing themselves to both manufacture PPE, even manufacture some of the other equipment that's being used, including the ventilators. There are a number of different things being done to sterilize, some of the equipment using like the masks, ultraviolet irradiation, vaporized hydrogen peroxide to sanitize N95 masks. So there's also been a huge, and I saw this on one of the news sites this morning in the UK, some volunteers that are making PPE. That same thing's happening in the United States. And so people around the country, it's almost like a war effort where people around the country are rallying to support our caregivers, which has been really gratifying to see.
Yeah, it's amazing. And what approach are you taking to testing, or does that vary across each state?
Wow, that's a really interesting environment. And unfortunately, you have to be much more clinically knowledgeable than I am to understand this. But I can say this, there's been an explosion of innovation and companies developing different testing methodologies. And the problem is that there's not a uniform test that the scientists or the physicians are tending to say is the best. But there's an explosion of organizations that are developing and rolling out these tests. And I can say that the testing environment is much better today than it was a week ago or 2 weeks ago. Now, the dilemma comes in almost more in economic terms, is because there's a close relationship between testing, at least a perceived relationship between testing and returning to normal in terms of our economic activity. There's some people that believe that we could return to normal on a geographic basis. In other words, some areas, some cities might still be in a lockdown, where others, people are free to move about. To really do that effectively without looking at second and third waves or surges of the pandemic spreading is through widespread testing. And so you'd have to have tests. Some people believe that to really be able to do that, you'd have to be able to test about 80% of our population. Well, with over 300 million people in this country, you can see those numbers are overwhelming. So I don't know where this is all going to go. I can say that the testing environment is still a problem. We still don't have enough tests. It would be great if we could test people that are asymptomatic. That's just not the case right now, but it is a better testing environment than it was just a few weeks ago.
So I want to ask you a few questions about the the healthcare system, really, and the impact that this is having. What's the biggest change you've seen in the healthcare system as a consequence of the pandemic?
Oh gosh, that's an easy one. It's been amazing to watch the emergence of virtual visits or telehealth, or somehow seeing your provider with your phone or computer, as opposed to going into the hospital or going into a physician's office. There are doctors' offices. Now, again, keep in mind, some of these doctors' offices are part of health systems. Some of them operate independently, legally independently. But many physician practices have completely shut down to walk-in traffic. And some of them are suffering significantly. Others are, well, I'm sure they're all suffering significantly, but others are able to have their patients' visits through a virtual visit, including being able to use video capabilities to either look down someone's throat or look at a rash on their hands or whatever it might be. Same thing with health systems. Now this technology was there before, obviously, with a very slow acceptance rate, both by the provider community here and also by the general public. In fact, I've had a number of health systems tell me that prior to the pandemic, they had about 90% of their visits were live and in person, and 10% done in some kind of virtual way through the phone or a computer. And that has, in literally weeks, has done a complete flip. and that it's like 10% of their visits are now live and in person, and 90% are virtual. That kind of switch in a matter of weeks is unprecedented. It takes a lot to change how healthcare is provided in this country, and I think everywhere. It takes a long time for people to feel comfortable with it, both on the provider side and the consumer side. This has been literally like flipping a switch. And part of the talk now is that the old saying about the genie's out of the bottle. It's going to be hard to put that genie back in the bottle. It's going to be hard to go back to that 90-10 split where almost everything is delivered in person. We believe that this acceptance of virtual visits is going to be permanent, at least at some level.
And that's really interesting because we've obviously seen a similar thing here. I don't know about the percentages, but much more virtual contact with patients is becoming normal, and a similar speed of change as well.
Yeah, and I like it. I think it's a great idea because who likes to get in the car, drive X number of minutes to go park and navigate your way, wait in the waiting room for a certain amount of time. That whole process, depending on where you're going, could take hours. It's much better to dial someone up on the phone and or your computer and get services that way for those things that can be covered. I think it's much more convenient, and that's why I think it's going to stick.
Yeah, excellent. And just thinking about the less presentations, we've seen quite a drop in attendances and admissions for things like strokes and heart attacks and cancer referrals. Are you seeing something similar there?
That has been by far the biggest impact on health systems in our country. So one of the things that happened early on in this pandemic was that our federal government, through our Centers of Medicare and Medicaid, asked our hospital providers to essentially eliminate as many of the elective procedures as possible. Now, heart attacks and strokes don't fall into that elective category. Nobody chooses to have a heart attack. But things like knee replacements or other types of surgeries, they've been asked to hold off on those to create room in the hospitals for the pandemic surge. Yeah. And that has happened across the country, and it has been financially devastating to hospitals. So a typical hospital right now would be operating at about 50% of their normal revenue. And many of them, so you hear about New York City and Detroit and New Orleans and some of those big cities. This is a very geographic pandemic, at least in its current state in the United States. So the hospitals that are out in other communities, like the town I live in, Grand Rapids, we have a number of COVID cases, but not nearly as many. And so the revenue impact for that on these hospitals has been just unprecedented, and to say it's huge is an understatement. In terms of cases like heart attacks and strokes, and I would throw trauma into that. Here's an interesting statistic I just heard about, and for 1 week time period in the month of March, we had fewer overall deaths in the United States. In the same week last year, in this week of March, we had like 55,000 deaths for all causes, and this same week this year it was 45,000. Wow. And so what it tells you is we're less active. And so we're not driving as much. I'm sure that there are fewer heart attacks. I'm sure that there are fewer strokes. Perhaps some of those are related to activity. It's interesting. You kind of laugh about it. If your sole objective was to keep people from dying, then you would just tell everyone to stay home. Well, that's obviously not a long-term solution, but it does. It has a couple different impacts. There are fewer people dying, but it's been a financial catastrophe for our hospitals and health systems here.
Yeah, so the future financial sustainability of the healthcare system is under threat, really?
It is, and it depends on the size and the nature of the health system or the hospital before this started. So one of our measurements, and I can't remember if this is used in the healthcare environment in the UK or not, but because our hospitals are independent from our federal government and independent organizations, they have their own balance sheets, and we measure their balance sheet strength by a measurement days cash on hand. How many days expenses do you have in terms of cash and investments on your balance sheet? Mm-hmm. And so it is not unusual for a hospital or a health system, a healthy one, before all this started, to be at, say, 300 days cash on hand. In theory, it doesn't really play out like this, but in theory, that would suggest that if they closed down today, they would have enough cash to satisfy expense. If they had no more revenue today, they would have enough cash and expenses to last for 300 days. Because of the investment market decrease and the huge losses that they're incurring, it's not unusual for that health system to be going from about 300 days cash to 150 over just a couple months time period. Mm-hmm. That's amazing. Yeah. Now, if you're a health system that starts with 300 days, it's a kind of a bad thing. Not kind of, it's a very bad thing, but you could survive. If you're a health system that started with 100 days cash on hand, boy, they're scrambling for liquidity right now. And that's a lot of what organizations are doing, is they're trying to shore up their balance sheets. They're getting lines of credit established. They're doing what they can to make sure that their balance sheets are as strong as they can possibly be while they're incurring these massive operating losses.
So do you think that the system will look quite different after this? Do you think some organisations won't survive it and things may have to rationalise in some places?
Yeah, that's, I wish I could, that is such a simple question. I think the short answer is yes, that there will be some hospitals that will not be able to survive on their own. There has already been a movement toward mergers and acquisitions and the development of larger, both from a geographic and then a revenue perspective, larger health systems. And my guess is that this environment will exacerbate that or increase that activity. So you'll see the continued development of larger larger health systems, multi-hospitals getting together to form larger health systems. I think that will be the case. I think you're going to see in some of our rural communities really just maybe not a complete closure, but a redefinition of what it means to be a hospital. In other words, there's hospitals in some of our small towns and cities that might have 25 inpatient beds. Maybe that town doesn't need an inpatient capacity. If you go back to our discussion about telehealth, maybe they need to have an environment where you can deliver babies and you can have emergency care and stabilize patients. And then through telehealth, get patients to a state where they could either be discharged without being an inpatient or transferred to a larger metropolitan hospital. Some of those things I think are already underway, and I think that will continue to development. Whereas maybe it just doesn't make sense to have a full service 24-hour inpatient hospital in some of our local communities. Even within our big cities, I think you're going to see hospitals that will have to redefine the types of services that they provide, just in order to withstand this financial blow. So I do think that there will be some shakeout after it's all said and done. But I would say it's very difficult in our country to close a hospital. They are community assets. They're viewed as jewels within the community. They're a huge job provider within a community. It's a very difficult thing to close a hospital. So these end up being, played out politically. They end up getting played out by the local media. They're very controversial. And so closing a hospital or restructuring a hospital, even redefining a hospital, can be a very complicated process in this country.
And here, obviously. I read that some states are thinking about beginning to reopen. So does that mean that you're beginning to think about recovery, or is it too early?
Well, that's technically it's too early right now. There's a lot of talk about it in terms of how to go about opening back up, and some of it goes back to that testing that I was referencing earlier. Here's something that you're not going to hear about in the media, but it is also a consideration and factual. But social isolation has very negative long-term health implications. If you add to that, if we are in an extended economic downturn, an extended recession, and turning into a depression, that joblessness also has very significant long-term health implications. There are people that die from those things and they fall into this category of what we call social determinants of health. And what you don't hear, what you see every day on the news, in fact, I have it on the TV in my office here, how many people have died in the last, X number or X number of months because of COVID-19. What you're never really going to hear about, because it's harder to pinpoint, but how many people die or suffer from social isolation and other healthcare issues related to not being out and about, or not having a job, not having health insurance, and all those kinds of issues.
Yeah.
Partly because those take longer to develop. So where do those lines cross, where the decline of COVID-related illnesses and deaths gets to a point that it is where we want to avoid the increase in those social determinant of health-related maladies? I don't know where that line is, and that's part of part of our politics here is we live in a hypercritical situation. They're a hypercritical environment. As soon as a politician decides to open up the economy, the next person that dies from the COVID-19, there'll be all kinds of criticism for opening up the economy. But who's talking about that other side of the equation? That is the economic impact on people's health, the isolation impact on people's health. It's a long way of answering your question, or answering your question, is that we're not, really nowhere is at a state where they could completely open up right now. But there is discussion about how do we go about making that decision. And the question will be how much of that decision is based on science and how much of it is based on perception and media reports, all of that kind of conversation versus, just the pure scientific knowledge. People do die every day from all kinds of sources. And so how do we make that decision about, opening back up when it does mean that people will die from COVID? And from my perspective, it needs to be a data-driven decision that includes many other factors.
Yeah, definitely. And that's a really interesting way of thinking about what the long-term impact of the pandemic is going to be. We're spending quite a lot of time talking about the future mental health impact for people who've been involved in the pandemic and been working in the hospitals as well.
Oh my gosh, yes, that is something that, again, you hear about every once in a while, and that is real. Another thing, if I could just go off on that tangent just for a moment here, but we don't do a very good job of funding and providing for mental health services. And I'm hopeful that this will start to shine a light on that we would do a better job of all kinds of mental health, ranging from substance abuse through, all kinds of illnesses to those issues like social isolation and what that means to our society. And so I would like to think that maybe one of the outcomes from this whole thing, if we could look back with a objectivity, would be that we would improve the way we handle mental health in the United States.
You've already talked about a lot of these, I think, but are there any other lessons that you think are going to come from this pandemic that will impact how healthcare is planned and delivered in the future? You've already mentioned the technology and the virtual appointments. Are there other things that might change?
Well, I might. I'm sure there is, and I might answer this question with maybe in four ways. Something I'm hopeful for, something I'm skeptical about, something I hope is a bare minimum, and then maybe some reality. On the hopeful side, I am hopeful that, and we just touched on this a little bit with mental health, but I would expand it to all of public health, that we do a better job of funding of public health. That is an unfunded part of our society. If you look at the data compared to the UK, it's significantly different. I would hope that I'm hopeful that after this is all said and done, that we would take a whiteboard and just start fresh with, okay, how should we fund public health and coordinate that with the acute care sector of our healthcare industry? Mm. The skeptical side of me says that we have such a toxic political atmosphere here, and it's not just the political side, because we as a populace, we elect these folks, and so that same divisiveness is throughout our society. That it's going to preclude a lot of honest debate and deep debate about some of these issues. I know that toxicity is oftentimes directed at our president, and certainly President Trump is bombastic in many of his comments. But it really is a two-way street. And while he might be more bombastic than others, that toxicity runs deep, and it's both right and left of center. And I am skeptical that environment will really that it will preclude an honest debate about things like how health insurance should work, and what about our uninsured, and what about public health. What I hope as a bare minimum is that we study about pandemic preparation. A good friend of mine is a gentleman by the name of Mike Leavitt, who was not only the governor of one of our states in Utah, but he was also on one of the President Bush's cabinet as Secretary of Health and Human Services. And he had a quote recently, something along the lines of, if you prepare for a pandemic before it occurs, you're viewed as an alarmist. If you prepare for it after it's already started, you're too late. And I think what's become abundantly clear in this country is that, and I think quite frankly, you make this argument around the world, that we were largely unprepared for a pandemic of this magnitude. And so I think at a bare minimum, everyone would agree that we have to have better science and better preparation for pandemic. So the reality to what's going to happen in the United States is also centered around that we have an election coming up in November. Our presidential election, which is every 4 years. We now know that it's going to be President Trump running against the Democrat nominee, Joe Biden. That may tell us something in terms of how that election, not just at the president level, but through all of Congress, both on the Senate and congressional side, the House of Representatives side, it will tell us something about what the next direction of this country might be. And healthcare is going to be a central part of that debate. It would have been anyway. Because of our uninsured and because of the high amount of cost that healthcare takes from in our general economy, how much it is individuals have to pay through coinsurance and deductibles and so forth. It would have been a major part of this election anyway. You bring in this pandemic, and there's going to be a bright white spotlight on healthcare as part of this next election. So the reality is, all of these things that we're talking about could go one direction or another depending on the outcome of this the selection. And so that's time will tell, right? It will be very interesting to watch. And those of us that, one thing it's 100% clear to me is that at the end of the day, there will still be a healthcare industry. People will still need us, and we still need to financially manage our healthcare environment, whatever the policies are, in a prudent way, which speaks well in the long run for organizations on both sides of the pond here, like HFMA.
Joe, that's been so interesting. Thank you for taking that time to talk to us today. It's reassuring to hear that we're facing a lot of the same problems, and but also that we're tackling them in a similar way as well. So thank you for that.
Well, again, Sarah, it's been my pleasure, and thank you for having me.
Part of our role at the HFMA is to support people to feel less isolated in their work and decision making at this time by sharing learning and experience from other regions and countries. HFMA Talk podcasts are being shared across the globe with our finance colleagues in the USA and Australia so that we can all learn from one another. To support our members and colleagues, all COVID-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. We are providing regular podcasts throughout the pandemic covering a range of areas. If there is a particular aspect that you would like to hear about, please let us know. The HFMA will be providing webinars on a range of topics to both support the immediate needs of the NHS finance community and future CPD requirements. We have also launched a forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. You can sign up via the link in the network section of our website at hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.